Hello, I'm Warren Hall, the National Manager of Support Services for the American Liver Foundation. The American Liver Foundation is the nation's largest nonprofit serving people with liver disease. We provide a voice for patients with liver disease, their families, and their caregivers. We do this through education, support, research, and advocacy. I want to welcome you to this presentation, which is part of a series of podcasts and short videos that are sponsored by Bayer Pharmaceuticals. In these presentations, medical experts will be discussing imaging and image-guided therapy, screening, imaging diagnosis, and treatment options, especially for the early detection of liver disease, which is so important in its treatment. Our presenter today is Dr. Thomas Schiano. Dr. Schiano is the Director of Adult Liver Transplantation and a faculty member at Mount Sinai Medical Center in New York City. He's also many other things, which are too numerous to mention during our short time together today. So I'll just say, Doctor, thank you very much for being with us for this presentation.
Thank you, Warren, and thank you for the ALF for all they do in increasing awareness of liver disease. It's extremely important these days.
Thank you. Yeah, thank you for that. And we try to do our best in this area. So the few questions I'll be tossing out at you today have come from people who have contacted the American Liver Foundation helpline. People call us all the time with various questions. And so we've gathered a few to fit into this, our topic today. And we'll look forward to your responses to these questions, or please feel free to take it in whatever direction that you would feel is most advantageous for our discussion. So the very first basic question that folks come to us with is, which tests are the best when it comes to identifying any liver challenges?
Well, the best tests are the simplest. Blood tests can pick up abnormal liver chemistries indicative of some liver damage. I think the best sort of test is to make sure that you are following up with your physician, who can take a history to see if you have any risk factors for chronic liver disease. For instance, if someone received a blood transfusion for a motor vehicle accident in the 1970s, they may have had an exposure to hepatitis C. If they have a family member who has hepatitis B, they may be at risk for having hepatitis B. So the history and the physical of really the primary care physician to begin with is the most important first step. These days, the most common cause of chronic liver disease is fatty liver. Almost 15 to 20% of the adult population has fatty liver. And this can occur in people who have diabetes, people who are overweight, people who have high cholesterol, people who have a family history. During the COVID pandemic, many patients have gained a lot of weight. All of us have. We sort of term it the COVID-15 sometimes instead of the COVID-19, because people have gained 15 pounds. And that has exacerbated some pre-existing fatty liver. Unfortunately, also during COVID, people are drinking a little bit more, and this is also potentially worsening some baseline liver disease. So I think the first step for anyone, to go to your doctor. They'll be doing routine tests and a history and a physical to really ascertain, are you at risk for having a liver condition? And then we take it from there if something is found.
Okay. The question about the viral hepatitis, we get a lot of contacts from people who are the baby boomers and older, and they'll say, I don't know how this happened. My lifestyle is not conducive to certain things. And we say, well, let's go back a little bit. So that's a really important point for people who may be confused, certainly, if they find that out.
And because of the wonderful medicines we have to treat,
yes,
to cure hepatitis C and to treat hepatitis B, it really is paramount for the person to really be screened and tell everything to your private physician and let them do the appropriate basic testing.
Right, right. So another question, do I always need a biopsy? Some folks will say my doctor wants to do it. Other people will say my doctor doesn't want to do it. And how would you respond to those inquiries?
Well, I think that the number of biopsies has decreased over the years because of hepatitis C treatments. We used to have to biopsy everyone, but we don't biopsy anyone anymore because the cure rates are so high, almost 100%. So you don't need a biopsy unless the physician is unaware of what's going on. We have wonderful, what we call non-invasive modalities to stage disease. So if someone is diagnosed with fatty liver, you can do a fibroscan. A fibroscan is like a sonogram. It can tell you how much scarring is in the liver. It's much better than some serologic tests, some blood tests that we have. Having more data is always important when you're talking to a patient. I don't routinely do biopsies in individuals who have well-established disease and we know what's going on. However, there are many cases where we're not sure of what's going on. There may be more than one condition going on. And then that's when a liver biopsy is warranted. Here at Mount Sinai, we're very lucky. We work with wonderful liver pathologists, some of the finest in the country, because some of these biopsies are extremely difficult to interpret. So the same way that one may need a second opinion as to what's going on with them clinically, you may need a second opinion what's going on with a biopsy when it's performed.
Right. And so if a physician does not want to do this, a patient should not be concerned that they're necessarily missing an important piece of a diagnosis. Correct. Right. So they're not missing out on anything.
Absolutely correct, Warren.
Okay. Thanks. So another question, I seem to need many follow-up imaging tests. Should I be concerned about the radiation or other exposures to this technology over time?
Very important question. When a person has cirrhosis of the liver, they are at risk for developing liver cancer, no matter how significant the disease is, no matter what it's from, whether it's from fatty liver, from hepatitis. A person who has cirrhosis is at risk for liver cancer. That risk is about 2 to 4% aggregate annually, which means that if one has had cirrhosis for 10 years, their risk for liver cancer, developing liver cancer, is about 20 to 25%. So when someone has cirrhosis, the standard of care is screening them twice a year, every 6 months, with a blood test, which includes a blood test called an AFP, alpha fetoprotein, and an imaging study. It's somewhat debatable as to what imaging study one uses. Our societal guidelines say you could use sonograms. However, as specialists, we feel that it's better to screen someone with what we call cross-sectional abdominal imaging, which is either a CAT scan or an MRI. Many people are a little on the heavy side, and sonograms are not as objective. They're what we call operator dependent. The findings may be related to the experience of the ultrasonographer. So we feel more confident with getting a CAT scan or an MRI. Now, MRIs do not have radiation exposure, CAT scans do. So here at our center, we perform more MRIs than CAT scans. Unfortunately, if one is claustrophobic, it complicates the issues with CAT scans. If someone has a pacemaker, they may not have a claustrophobic with an MRI. If someone has a pacemaker, they may not be able to have an MRI. If someone has kidney issues, both MRI and CAT scan is problematic. So the frequency of imaging studies is standard of care every 6 months when someone has cirrhosis. It is the choice of what imaging study to use. That's at the discretion of the gastroenterologist or the hepatologist. MRIs don't give any radiations, CAT scans do, so it is not wise to have frequent CAT scans.
You know, when you were speaking there, my mind went back to my own mother, who was very claustrophobic, and she had a thyroid problem, and so she needed the MRI, and they gave her a little dose of a little something to keep her calm. Me and my brothers would say, let's take her to happy hour, then we'll then we'll go do the test. But then some certain places had the open MRIs, but I don't know in terms of the actual effectiveness of or detail in the open versus the closed. But there definitely is that patient feeling issue in that regard.
With regard to these scans, I would say, again, I'm biased because I'm headquartered at a big liver center, but the performance of the CAT scan and the MRI is almost more art than science, because the characteristics of a liver cancer, which is what we're looking for with the scan, is determined by the contrast, the dye that's given intravenously, which all of the scans need. For the liver, a CAT scan or an MRI without dye is not helpful. So you need the dye. And I think that it's important to go to places that do a lot of scans. I would say preferably at a university center, at a big radiology center where they have experience with doing scans. Again, my own personal bias is that the open MRIs may not be as good. So, going to happy hour beforehand, or a little medicine, or, I have to say, I was claustrophobic with an MRI. I put on the nightshade. I put something in my ear, played some bad music, some bad elevator music, and I was fine.
Yep. Yeah. So you mentioned there about using the dye. So if someone has a report, and as we know these days, it's wonderful that patients have access to their testing records. It's also not so good because so many people try to read it and interpret it on their own, and certainly none of us are that equipped to do that. Even at the Liver Foundation, people call us and say, here's what my testing said, can you help me? And we don't. We're not allowed to, certainly. But just in regard to the dye, is that when it says with contrast?
Yes.
Is that what that's referring to?
Exactly, it is.
Okay, great. Thank you so much. Now, I think our last two questions, you may have touched on these somewhat, but how can the doctor tell by looking at a scan if something is a simple cyst, or if it's actually cancer, or the doctor maybe say that, oh, you have a lesion? How can, without that biopsy, and I think this is probably where most people say, oh no, I want a biopsy, because how can you tell from a picture? So how would we respond to that?
In the setting of cirrhosis, a very good question, Warren. In the setting of cirrhosis, there are what we call pathognomonic findings of liver cancer on imaging studies. So very conclusive imaging studies, as I mentioned, about the dye, how the dye is taken up by this lesion that you're talking about. So it's very rare, actually, that we have to biopsy these lesions, because they for us, they're clear cancer when we look at these imaging studies with the radiologist. Now, it's not so cut and dry, though. In the liver that has cirrhosis in it, there are a lot of nodules. That's what a cirrhotic liver looks like. It has a lot of these knots or nodules. And sometimes if you get a scan, you see a little nodule and the radiologist doesn't know. You're unsure of what's going on. So in that case, what most centers do and most people do is, instead of getting a scan in 6 months, you'll get a scan in 3 months, because a nodule in the setting of cirrhosis will not grow, whereas early liver cancer will. It's important to remember also that the MRIs and the CAT scans are very, very good at discerning liver cancers down to about a size of 1 centimeter, which is about a third of an inch, which is quite remarkable. Wow, however, if something is very early and is below 1 centimeter in size, you may not be able to readily identify it. The issue with biopsies is that, number one, there's always a risk of bleeding because tumors are vascular. Number two is, because these lesions are so small, we're talking about 2 centimeters, 3 centimeters, so an inch in size, they can very easily be missed. And then if they're missed, you sort of have a false sense of security that everything is is fine. So what I would recommend to patients is that if they're seeing their local doctor or local gastroenterologist and a screening scan shows a lesion, before it is biopsied, I would say consider getting an opinion with a gastroenterologist or a hepatologist with regard the need and utility of a biopsy. And maybe it just would take repeating the scan, say, a little bit sooner to sort of obviate that need.
Right. And I guess over the years, so much of this technology has improved.
Absolutely.
I think sometimes the patients, especially if it's those who are, let's say, more mature, they're thinking back to what they remember, maybe even from when their own parents had these things done. It's almost like we mentioned the hepatitis C treatment. A few years ago, it was very challenging and many people stopped it because it was so much. And now, it's a couple months and you're finished. And so I think it's the same, that we need to try to get patients to understand that just like our smartphones have improved and our high definition TV, this medical machinery and technology has improved so much that we need to advance our understanding of just how clear these pictures are.
Absolutely. And the goal of this increasing awareness is to detect these things early, because people should not be afraid when they hear cancer that I'm going to die. I want to ignore it. But if they're picked up early, they're readily curable, and people don't need chemotherapy. There are different interventions, which I think you'll probably be talking about on a future program, that can readily cure these things. So preventive medicine is the goal here. And I think that if everyone is following up regularly with their doctor and they have easy access to subspecialists, people will be okay.
Right. And I'm glad you use that phrase, early detection, because certainly that's the goal of this programming that we're doing in this regard, and that is to encourage people to understand that the testing and the technology is all there with the goal of catching this early, because as you said, so much of it is curable. Fatty liver can be reversed, right? We know that, and not with any fancy medicines, just with a really good diet and lifestyle.
It's a hard thing to do, but it's doable. Yes.
Yes, especially during COVID-15. I've been in education my whole life at the higher ed level, and we used to talk about the freshman 15, right? Yes. We tell them they don't have mom's home cooking anymore. But right. So finally, let's move into your own area of expertise, and that's transplantation. So what would someone expect? So they do find out that their liver may be at a stage where, unfortunately, it's not going to recover, and the physician tells them that she or he would like to refer them for a transplant. So when this person comes to you, doctor, what generally is what someone should expect? What kind of testing? What is that procedure for them going to look like?
Well, I want to preface this, Warren, by saying also that I deal with patients who need liver transplantation, but it is my philosophy, and many philosophies, the program and other programs, that if you could avoid a liver transplant, you avoid a liver transplant. And that's what we want to do. So coming to see us doesn't mean that, well, I'm heading down the road of transplant. If there's anything we could do to prevent that, we would like to do that, right? Unfortunately, many of the patients that are referred to us are referred late. So there are no possible interventions. So one thing I want to throw out there is that, we should see patients a lot earlier, because there are things that can be done to sort of avoid the concept of a transplant, treating and curing a tumor before that becomes the indication for the transplant. But when the liver disease is advanced and we're seeing patients, we do a very comprehensive evaluation. They see a social worker to make sure that their insurance is okay. You can have great insurance, but if the insurance doesn't pay for medications, that's a problem, right? Yeah. Which you need some medications for the rest of your life after a transplant. We review the imaging studies. We have them see a heart doctor, and then a lot of it is education, because it's so complicated how one gets the gift of life, how one gets a donor off of the list. Even if you're in the medical profession, it's very complicated what the MELD score is. So a lot of it is just beginning the education process for the patient and for the family and for the caregivers, because there's a lot of stress that comes with this chronic condition. And then once we put someone on the list, we talk to them about how likely it is they're going to get a transplant. Do they need to consider a live donor? We continue to get imaging studies to make sure that they don't develop cancer in the interim. And we try to control and manage the complications of cirrhosis, like fluid buildup called ascites, or varicose veins bleeding, varices, encephalopathy, confusion, which is a major problem for patients and their families. So it's a very long process. We try to start early, and we're with the patient all throughout to try to get them to transplant and get that gift of life that they so desperately need.
Right. Well, now my final question. I mean, this is a great discussion and we can go on, but because the time is limited, the other thing people will say to us is, oh, you know, I'm going for so many tests and I got to see this one, I got to see that one, I got to see that one. What we try to help people to understand is that no test is wasted, right? There's a reason why folks are going to see physicians perhaps in various disciplines, or there are different types of testing. And so what we try to encourage people is to say, you know, each of those tests are important, and each one, even though your doctor may not sit with you and give you full results from each of those individual tests, nothing is wasted, right, in the testing that's done.
Absolutely, nothing is wasted. All of these things are essential. But what I would also say is that I appreciate when patients are very proactive and they keep us on our toes, like you said, looking at the medical record. I embrace that because I think patients have to be playing a role in their own care. So ask questions. The physician is there to answer your questions. We work with wonderful nurse coordinators and other staff. And as I mentioned, it's a complicated process. So ask the questions, be proactive. Physicians should embrace that and welcome that. So really play a role in your own care.
Well, doctor, thank you very much. And I really meant it when I said we could go on here for a long time, but you know, we thank you for the insights that you've offered to us today and the information. And so for our viewers, if you're looking for more information on liver disease, liver wellness, go to our website, which is www.liverfoundation.org. You can also check out our YouTube channel for more informative podcasts and video programming, such as the one that we've done today. And I mentioned early on in our discussion that the questions that we posed to the doctor today came from our national helpline. And we invite you, if you have questions, to contact us through that helpline. You can go to our website where we have live chat, which is very popular these days. You can email us at info@liverfoundation.org, and we'll respond to that email, or you can call us. And our number is easy to remember. It's 1-800-GO-LIVER, which is 1-800-465-4837. And finally, I want to give another word of thanks to our sponsor, Bayer, for making this program and this series possible. We hope that we'll see you again at another video presentation.